So with that, again, I'd just like to reiterate that we're very pleased to be bringing you this policy round today, which will share findings from research supported through a knowledge synthesis funding opportunity that CIHR launched in 2011 as part of the EIHR renewal initiative. Also, I wanted to acknowledge that we have a large number of registered participants for the session today. Currently, we have 103 attendees on the line, so we're really excited about that and hope that it'll generate some interesting discussion towards the end of our session. So just quickly, I want to review the learning objectives for today. So the primary objectives that the presenters have identified are to review the results of a recent meta-analysis on the effects of ABS on hospital mortality, readmission rates, volume of care, and severity of illness, to discuss the potential effects of ABS on post-acute community care capacity, to identify the potential risks to equitable access to post-acute care under ABS, and finally, to understand the potential policy implications of ABS for healthcare systems more broadly. In terms of the outline for how the session will unfold, I'll introduce the speakers. We will hear first from the research team on the different aspects of their systematic review and meta-analysis on ABS. After that, we'll hear from Stephen Lewis, who will speak directly to the policy implications of the research presented. And after the presentations, we will take questions through the chat mechanism and help to facilitate continued connections and dialogue. Once the webinar closes, a survey will pop up on your screen, and we'd appreciate you spending just a couple of minutes to let us know what you thought of today's session. We'd also like to acknowledge that today's webinar, though hosted by CIHR, is a true collaboration among all the organizations listed here, including Canadian Doctors for Medicare, Simon Fraser University, and McMaster University. Well, next, I'd like to introduce you to the speakers on our webinar today. Our first speaker is Karen Palmer, the principal investigator on the knowledge synthesis grant that will be presented here today. Through this work, Karen led a 19-member international research team in a systematic review of the global evidence on the effects of activity-based funding in hospitals. Karen's passion is comparative international healthcare systems and reform, with a particular interest in the differences and similarities between the U.S., European, and Canadian healthcare systems. Danielle Martin will be presenting today as well as part of the research team who studied ABS. In addition to her role as the VP of Medical Affairs at Women's Health College, Dr. Martin is also an assistant professor in the Department of Family and Community Medicine and the Institute for Health Policy Management and Evaluation at the U of T. You may also recognize Danielle through her previous role in helping to launch Canadian Doctors for Medicare in 2006, where she chaired their board until May of 2013. Thomas Agorista is a research fellow in the Department of Clinical Epidemiology and Biostatistics at McMaster University. He completed his MD in 2006 and postgraduate training as a hospital-based general internist in 2011 at Geneva University Hospitals in Switzerland, where he also worked in the divisions of quality of care and clinical epidemiology. Thomas is another member of the research team who will be presenting here today. Lewis, who is the president of Access Consulting Limited and adjunct professor of health policy at Simon Fraser University. Stephen has served on various boards and committees, including the Governing Council of the CIHR, the Saskatchewan Health Quality Council, and the Council of Canada. His knowledge and analysis of health integration issues has made him a valuable resource for the health policy organizations across Canada, and Stephen is joining us today to provide some insight on the impacts of ABS on the broader policy landscape. So a big welcome to all of our presenters. With that, I would like to turn it over to Karen Palmer, who will be leading the discussions today. Karen.
Okay, thank you, Amanda. Good morning to everybody. Thanks so much for joining us today to discuss the results from our study on activity-based funding of hospitals. We're very happy to be with you to share our work. So during the past 2.5 years, we undertook a systematic review and meta-analysis of activity-based funding of hospitals. We were interested in understanding how activity-based funding effects of hospitals might affect mortality, readmission, discharge destination, severity of illness, and volume of care. And I'll explain what we mean by each of those variables in a minute. As Amanda said, our research team included 19 individuals based at several universities and institutions in Canada, Switzerland, and Australia. And we met weekly by Skype, by phone, in person throughout the course of conducting this research. And it was truly an international collaborative effort, so we're very excited to share the results that were published in PLOS ONE a few weeks ago. Okay, I pushed the down button, Amanda, and it didn't go to the next slide. What do I do?
Karen, did you click on the first screen first? Just do a quick click on the slide and then with your mouse?
There. Perfect. Okay, thanks. So why did we do this study? What was the rationale for it? A few years ago, we learned that activity-based funding was being considered for implementation in Canadian hospitals as an alternative to traditional global budgets, for example. And so we wondered what effects this funding might have in our hospitals here and also around the world. We were interested to know whether the benefits of activity-based funding would outweigh the harms or vice versa. And we also wanted to know whether activity-based funding is an effective and safe way to fund hospital care. So what do we mean by activity-based funding? Activity-based funding is an alternative to global budgets or other funding mechanisms such as cost-based reimbursement, which was implemented in the United States before activity-based funding. And under activity-based funding, hospitals are paid a predetermined fixed fee per episode of care, and that fee is intended to fund the bundle of services provided to each patient with a particular diagnosis, regardless of the actual resources used on a particular patient. The hospital services under activity-based funding are prospectively classified into clinically meaningful bundles of care, oftentimes called DRGs or diagnosis-related groups. They have other names in other jurisdictions around the world, but this one is pretty commonly recognized. And these are the services that are ordinarily provided to clinically similar patients admitted with particular diagnoses. The activity bundles are intended to account for patient diagnosis, the complexity of care, the type of care, the volume of care, and the intensity of care. So we discovered that there is much confusion in the literature about the differences between this alphabet soup of activity-based funding, or ABF, versus P4P, or pay for performance, versus FFS, or fee for service. So I'll go over the differences in these terms. Activity-based funding, under activity-based funding, hospitals receive a fixed amount for each episode of care delivered to each patient, regardless of the length of stay or the actual resources used. So ABF is really meant to replace other funding. Different from this is pay for performance, which is essentially a reward for meeting pre-established targets on quality or efficiency. Pay for performance can be used with any funding mechanism, from global budgets to cost-based reimbursement or any other. It's essentially a supplement to the base funding. Fee for service would be where hospitals would be funded for each reported activity. So whereas activity-based funding uses diagnosis-related group bundles to aggregate services for clinically similar patients, fee-for-service actually unbundles those activities and funds each activity separately. So our review focused on the first thing on this list, which was activity-based funding of hospitals. So now that we understand what activity-based funding is, what is it not? So it's not pay-for-performance. It's not BC's unique patient-focused funding, which is essentially a combination of activity-based funding and pay-for-performance and some per diem, and it's not per diem. So what is the premise of activity-based funding? Well, by this we mean what is it supposed to do, and why might healthcare systems implement it? Of course, different systems around the world implement activity-based funding for slightly different reasons, but generally speaking, activity-based funding is meant to reduce hospital costs, increase transparency and accountability of funding and spending, improve efficiency, reduce length of hospital stay, improve access to care through shorter wait times, And under activity-based funding, patients become revenue generators rather than cost drivers. So what was our research question? Well, we decided to look at the ways in which activity-based funding affects outcomes that we determined to be important to patients and hospitals. So the first outcome we looked at is mortality, and we wanted to measure this most important patient outcome because it relates to patient well-being. So we looked at patient deaths here. And we wanted to know how it affects the mortality for patients admitted to hospitals for an episode of acute hospital care. And we considered mortality to be a measure of quality of care. We looked at mortality in two different settings, acute care mortality and post-acute care. We defined acute care mortality as the death rate per population per common time period, starting at admission to acute care or at surgery. And we excluded mortality measured only in hospital or only from discharge, since the potential influence of activity-based funding might have been confounded by differences in length of stay in activity-based funding and in activity-based funding periods and no activity-based funding periods. We defined post-acute care mortality similarly to acute care mortality, except that mortality was measured starting from admission to post-acute care following a stay in acute care. So next we wanted to know how activity-based funding affects readmission rates in hospitals, which we also considered to be a measure of quality of care. And we defined readmission as the rate per population per common time period, usually at 30 days, for which patients might have been readmitted. We also wanted to know how activity-based funding affects where patients go when they're discharged from hospital or their discharge destination, which we also considered to be a measure of access to care. And we looked at the proportion of patients discharged alive from acute care to post-acute care rather than discharged to home. Next, we were interested to know whether severity of illness was different after activity-based funding among patients admitted to hospital, and we considered severity also a measure of access to care. We included severity of illness measures such as differences in case mix, or differences in diagnostic codes, or differences in DRG points, or differences in the number of patients with comorbidities. And lastly, we wanted to know how the volume of care is affected with activity-based funding, which we also considered to be a measure of access to care. For volume, we considered differences in measures such as the number of patients treated or admitted, or the number of procedures or tests performed. So to answer our research questions, we decided to undertake a systematic review of the worldwide evidence over the last 30 years. Why did we choose a systematic review methodology? There are two main reasons. First, because non-systematic reviews are highly susceptible to bias. And until now, there hasn't been a systematic review of this body of evidence. I think we all appreciate the passion we bring to our work, and the reason we did a systematic review is illustrated by this quote, which says, "The more passionate scientists are about their work, the more susceptible they are to bias." It's not really possible to be free of bias, but with a systematic review and a rigorous systematic review methodology, we had the best chance of doing that. Second, because the stakes are high with activity-based funding or any change to hospital funding, ABF isn't an intervention just at the patient level, but rather at the population level for a whole community or a whole province or even the whole country. So we felt that using a rigorous, state-of-the-art systematic review methodology was the best way to inform decision makers about what they might expect from activity-based funding. So that's sort of our starting point. So now I'll turn it over to Thomas Agaritzis, our colleague from Switzerland and McMaster, and Thomas will take us through how we did this study so that you understand the methodology of our systematic review, and then he'll walk us through some of the results.
Thank you, Karen. So we use a state-of-the-art methodology for systematic reviews and meta-analysis. We followed a very thorough 9-step process that is outlined here. We really started before anything else by defining the research question that Karen shared with you and defined the eligibility criteria and every step of our methods. Actually, we had rules for every step that we built into a manual for consistency across the team. We developed and conducted a comprehensive search strategy for the literature, We screened title and abstract for potential eligibility. We reviewed full text for eligibility, all that done in duplicate, as I'll show you. We abstracted data whenever it was possible quantitatively, and then it was not possible in a narrative but structured way. And then we assessed the credibility of each study, of the findings of each study individually, in other words, the risk of bias, and analyzed and summarized the outcome data, again, quantitatively whenever we could, in a meta-analysis, and in a structured narrative way otherwise. Finally, and we know there are lots of questions on that, we look at the explanation in the variability of findings. You'll see that one of our main results actually is a large variability in the impact of ABF that remains, for most parts, unexplained, as we'll show you. Next slide, please. So here is our, an outline of our search strategy. It was done in collaboration with a health librarian. We searched from 1980 onwards in all countries and all languages. Typically, these reviews are done in about 3 to 5 databases. We searched 9, the 9 outlined below: Mendlan, Avis, Central, HTA, and economic databases, Cochrane, etc. We also looked at the gray literature, personal files, reviews, websites, and consultations with experts. Here is an example of one of the search strategies, search strings for one database. There were 9 of them. This is just to give you an idea of how many search terms we had to use to actually be very comprehensive in finding all relevant articles. We considered as eligible studies for this review those that had original quantitative data that actually compared the impact of ABF versus an alternative funding system in acute care settings. This review is not specifically on the impact of ABF in post-acute care settings, but acute care settings. We also excluded studies that did not include a comparator group, that is a group with no ABF implemented in a jurisdiction, or a 0% ABF period, a before ABF period. And we included all analytical study designs, as shown in the next slide. The most common design was a before-after study, so a study conducted in one jurisdiction, and when the outcomes were measured before the implementation of ABF, and then gradually after the implementation of ABF. There were also studies conducted in multiple jurisdictions, so parallel control groups, for example, a group where 0% EBF was implemented and a jurisdiction where it was. And there was a third type of study design which combined these two, typically in different analyses or time series. I see messages that there are problem of volume issues. Can you hear me well?
Yes, you sound great, Thomas. I think it would just be helpful to make sure you're speaking closely to your mic and enunciating. But you sound great.
Thank you very much. Thank you very much. Screening was done in 2 steps, entitled and abstract and full text, and it was done by paired independent reviewers that were calibrated for inter-rater reliability. Now, where there was a conflict, it was resolved by consensus, and if not, by a third adjudicator, if necessary. Here's the result of the review of process. We found initially 16,000, more than 16,000 citations that were screened individually, and we screened 940 full text, which resulted in 227 reviews, studies, that looked at the impact of ABF on any outcome. In this specifically review today that we present to you, we looked at the 65 studies on the outcomes that Karen has outlined. Next slide. But just to give you an idea on the other outcomes, among the more than 200 studies that compared the impact of ABF with no ABF, there were 143 that looked at length of stay, 75 at some indicator of quality of care. These metrics could be very different across studies. There were studies that looked at pneumonia or stroke, for example, so the indicators of quality of care were very different. There were 71 studies that looked at cost and sweat the added efficiency. There were 8 studies that looked at administrative burden, and 31 that compared patient characteristics before and after ABS. However, here we present to you the 65 studies with the outcomes here in blue, so mortality, readmission, discharge destination, in particular to post-acute care. And in these studies, we also looked, as Karen told you, at volume of care and severity of illness. Regarding severity of illness, we were looking at that at admission, so to look if patients were more severely ill, but we also knew that this could be a proxy of risk selection possibly, or of coding, as we'll discuss in the results. So the 65 studies came from 10 different countries, Australia, Austria, England, Germany, Israel, Italy, Scotland, Sweden, and Switzerland, and the majority of them from the US, 50 studies. The most common study design was before-after, and there were actually only 3 that looked at parallel groups, so comparing 2 jurisdictions, and 3 that looked at time series or more advanced and thorough designs. As well, there were more than half, 36 studies that used a convenient sampling. So the authors used available administrative data. They were not really designing a study specifically for ABF. But 11 of them used a random sampling of institutions, and 90 looked at all eligible institutions. We assess the credibility of findings in each study, as some evidence is more or less prone to bias, looking at 3 domains: the documentation quality of data sources, the number of eligible outcomes that were simultaneously examined, and the comprehensiveness and appropriateness of the adjustment for any confounders. This resulted in a score that we categorized in advance as lower credibility, less than 4, and higher credibility, more than 4. So the individual assessment of each study can be found in the appendixes of our paper. And we included actually all the papers in the analysis and the results we'll share with you. But we compared the lower credibility and higher credibility results. So as I said, we tried to meta-analyze, so to combine all results quantitatively whenever it was possible using random effects models. However, often it was not possible because of the amount of information reported in the article. In that case, we still use a structured vote counting system looking at the direction of the effect, the magnitude of the effect, and its statistical significance. And again, these narrative summaries can all be found in the appendices of the paper for each study. Finally, and this is the last method slide before we look at results, we looked at 6 pre-specified subgroup analyses to explain the variability across findings. We compared the US studies versus the international ones. We compared study designs before, after, or more advanced designs. We look at the time elapsed after ABS implementation. Was it early after, in the 2 years after ABS implementation, that the outcomes were assessed, or more than 2 years? We compared studies that adjusted for confounders or not, the ones with higher credibility, as I've shown you, versus lower credibility. And finally, the time of the outcome assessment. For example, for mortality or readmission, was it the outcome within 30 days or more than 30 days? These subgroup analyses were actually the ones that we could analyze because the data was available in the study. You can, of course, imagine many others, but these are the ones we were able to apply in the analysis. So finally, some results now, and we'll start first by the quantitative data. This is the forest plot on the acute care mortality data. And you can see on the left side of this graph the list of studies, first the US and then the international, and then a vertical line in the middle which shows the no effect of ABF. So if you are on the left side, if a study is on the left side of this line, it means that mortality is decreased with ABF. And if it's on the right side, it's increased with ABF. So as you can see here, all the studies are pretty much in the center, showing no increased mortality with ABF. And the pooled estimate is an odds ratio of 1.03, going from 0.93 to 115. So a few studies, the smaller ones, those are more to the right, tend to show an increase, but none went significant, and overall, no real increase in mortality shown here. The results for readmission are a bit different. There are slightly more studies in the US and international, and what is striking here compared to the previous is the high variability. You can really see it's all over the place. Some study on the left with decreased readmission rates, some studies on the right, significant or not at both sides. And if you choose to pool, as we did, to combine all these results, you still arrive at an estimate that is null, no effect, 1.04, going from 0.93 to 0.16. But it is striking how much the results vary across studies. So as I said, we looked at all our 6 pre-specified subgroups to explain the variability. And for example, there was no difference clearly between the US and the international, or the higher credibility versus low credibility studies. Actually, we could not explain reasons for the variability we see here. Now, post-acute care, the way we looked at it is broadly defined as any intermediate level of care after acute hospital stay. In other words, anything but home with self-care. It is different in each country. For example, in the U.S. Medicare, it includes skilled nursing facilities, inpatient rehabilitation facilities, etc. And in the results I'm going to show you, we actually dichotomized into any post-acute care compared to home without any post-acute care. So the first plot is even here smaller to read, but what I'd like to show you again is the variability. You notice that the studies vary, slightly more on the right, slightly more on the left. But in contrast with the previous results, here they are much more consistently on the right, showing a clear increase with ABF. And when you actually combine them, the relative risk is 1.24, which means a 24% relative increase in discharge to post-acute care across all these studies. There was one subgroup of our 6 pre-specified subgroup analysis that explained some of this variability possibly. It's the location. So the U.S. studies on the top of the first part of the first plot actually show an even larger increase with a 28% increase on average discharge to post-acute care. While the 3 studies, and there were only 3 international studies that we could quantitatively combine, didn't seem to show the same effect. So this could explain some of the variability, but this is of modest credibility as there were only 3 international studies here reported.
Thank you, Thomas. So I'll summarize the findings that Thomas has taken you through in this table here. And I want to just remind you that if you're interested in digging into our results, we encourage you to do that. And we published 31 appendices in a supplemental file that you can download online. And we also published our study protocol, so you can see how we built the study and the decisions that we made about how to abstract data. So let's look at the first acute care mortality result. You can see that we divided the results to show the pooled analysis first and then the non-pooled analysis. So the pooled analysis showed no difference in acute care mortality, although there was modest variability. And the non-pooled analysis showed that early after activity-based funding was implemented, mortality increased, but that effect appeared to subside later. So for the early ABF, we abstracted the first data point after ABF implementation, And for late ABF, we abstracted the data point farthest from when ABF was first implemented up to 5 years after implementation. So we see the difference here between the pooled and the non-pooled for acute care mortality. So let's move to post-acute care mortality here now, meaning in this case, again, mortality measured starting from admission to post-acute care, following a stay in acute care. And here we see in the pooled analysis, no difference in mortality, though again with modest variability. And in the non-pooled analysis, we see no difference, but there was only one eligible study. For readmission to hospitals, we see no difference in readmission rates, but high variability across studies. And that variability means there is uncertainty about whether a jurisdiction can expect to see an increase in readmission with ABF. In the non-pooled analysis, we saw some increase in readmission early after ABF was implemented, and again with modest variability. And later on, we saw no difference in the U.S. studies, though with high variability across studies, and an increase in readmission outside the United States, though again with only 2 studies. So there's really little data on readmission rates outside of the U.S. The results about patient discharge to post-acute care after an episode of hospitalization are, of course, our most robust finding. And in the pooled analysis, we see an overall increase in discharge to post-acute care with only modest variability. And we also see a possible subgroup effect, as Thomas described, showing an increase in discharge to post-acute care in the U.S., but not so much internationally. But we did see in the non-pooled analysis an increase in discharge to post-acute care both in the U.S. and internationally, and again with modest variability. For the severity of illness, we were unable to pool these data, and so the non-pooled results show an increase in severity of illness with high variability and no difference between the U.S. and the non-U.S. studies. So were patients genuinely sicker when they were admitted to hospital after ABF? Well, it's hard to tell. They certainly appeared sicker, but we saw evidence that this may be attributable to differences in diagnostic coding procedures after ABF. So since activity-based funding tends to adjust hospital compensation for acuity, there's a financial incentive to code patients so they appear as sick as possible. And this, of course, maximizes reimbursement for a hospital. Upcoding could be appropriate if it represents legitimately better coding, or it can be questionable or it can be inappropriate. In Germany, for example, the introduction of activity-based funding led to a very large increase in one study that we looked at in low birth weight babies, and a decrease in normal birth weight babies over a 5-year period, but there was no biological or epidemiological explanation for this effect. So inappropriate upcoding seems probable here. In the United States, we reviewed one study showing an increase in, actually a decrease in overall case fatality rates with activity-based funding, and this was coupled with a large increase in the volume of septicemia diagnoses. So this combination is highly suggestive of inappropriate upcoding. So what's important about inappropriate upcoding, or any upcoding for that matter, is that to the extent it occurs, it's likely to undermine at least one of the policy objectives of activity-based funding, which is controlling costs to payer. So the last variable is volume of care, and we were unable again to pool these data, but the non-pooled analysis shows no difference in volume of care, though again the results were highly variable across studies. So just to summarize once more, because the results are so many and a little bit challenging to sort of cement in our brain, no difference in mortality, but results varied. No consistent difference in volume of care, but there was high to modest variability. A possible increase in readmission rates, again, high to modest variability. An apparent increase in severity of illness, again, high variability and some evidence of upcoding. And a robust 24% relative increase in discharge to post-acute care on average with modest variability. So our study identifies that there appears to be considerable heterogeneity across jurisdictions for some of the outcomes, and sometimes this means that activity-based funding works in one way and other times in another way, and our review identified really no clear pattern about when it works and when it doesn't. So policymakers, we think, should consider the implications of our work for patients and hospitals and post-acute care capacity, especially human resources, public funding, and the healthcare system. I'll turn it over now to Danielle Martin to discuss the policy implications of our study.
Thanks, Karen. So to try to boil down the results of this review in a way that helps policymakers who are grappling with what the best way is to fund hospitals. We've prepared a couple of slides about what we feel are the take-home messages around policy implications. So the most important, arguably the most important question that a policymaker might ask is activity-based funding of hospitals safe? If we're planning to move towards this method of hospital financing in Canada, can we have some assurance that it's not going to harm patients? And certainly with respect to the mortality findings, there doesn't seem to be any concern around increases in mortality or an ongoing prolonged increase in readmission rates that is found to be consistent across studies. Again, there is really high variability among these data, which may relate to the design of the studies, but may also relate to the contexts in which, the policy context in which activity-based funding has been brought into being over time in these various international jurisdictions. To the extent that we did see any pattern around readmission, because, and this is something that we haven't touched on very much, but there does seem to be a pretty general policy consensus that introduction of ABF tends to reduce length of stay in hospitals, and so readmission, of course, is something that everybody wants to know about. So the question is, if you know that in general length of stay goes down when you introduce activity-based funding, do people bounce back to hospital because they've been sent out earlier? And where we saw some patterns around that question, what we observed was that there seemed to be an increase in readmission early on, and then a trend either back down to nothing, down to no difference, or mixed results in the later post-activity-based funding universe. And so I'm also looking at the questions that people are putting forward around length of stay, and hopefully that answers some of those questions. Secondly, around safety is this question of severity of illness. Are patients actually sicker on their admission to hospital once you put activity-based funding into play? Because that is what the results suggest, is an apparent increase in how sick people are in the hospital system once activity-based funding becomes the predominant method of hospital financing. And to Karen's earlier point, which I think she covered very well, it may be that activity-based funding provides an incentive to code more accurately. And so the apparent increase in severity of illness may just reflect that we are more accurately coding how sick our patients really are when they arrive in hospital. But of course, the alternative explanation would be that inappropriate upcoding takes place because of the incentive to maximize revenue under this model. And of course, those two explanations aren't mutually exclusive. Next slide. The second set of policy implications that we think are really important coming out of this work are the implications for system capacity. A relative increase of 24% in the need for some kind of post-hospital care, whether that's home care, whether it's long-term care, whether it's inpatient rehabilitation, et cetera, is a very significant finding, particularly for the Canadian healthcare system, where some might argue, and I suppose I would be among them, that we don't have a whole lot of excess capacity in the post-acute care sector. So the question really for policymakers is, if this is a road that we are intending to go down, is our post-acute care sector ready? And if not, how can we make sure that it will be ready for what one might reasonably anticipate should be some substantial increase in need as patients exit the hospital after shorter lengths of stay and require more care in that sort of interim transitional period before they can be home without any help at all. Next slide. Or sorry, next point. Just again on system capacity, so one of the purported policy intentions behind implementing activity-based funding is that we're trying to provide an incentive to volume. We have a wait times problem in some areas in Canada, and we want to try to increase the volume of care being provided, assuming, of course, that all of that care is appropriate care. And so we were surprised, in all honesty, and this has been consistent, I think, with some other work that's been done in Canada, in the Canadian context, to discover that there doesn't seem to be a reliable increase in volume of care associated with the introduction of activity-based funding. And perhaps we can discuss more in the question and answer period if people are interested what some possible interpretations or explanations for that finding might be. But the ultimate, result is it doesn't seem to actually increase the amount of care being provided or the number of people being pumped through the system, and therefore might not have the same effect of reducing wait times that policymakers might be hoping or expecting. Now, finally, an important realm of policy implications for consideration around this set of findings is the implications relating to equity. So as you all know well, there is really high variability across Canadian jurisdictions as to how much publicly funded home care and other post-acute care exists in the system. And so, and certainly there's no obligation under the Canada Health Act for jurisdictions to pay for, in their public insurance plans, post-acute care. And so with a highly mixed and variable set of systems across the country, heading into a method of paying for hospitals, which are, medically necessary care in hospitals is publicly paid for in Canada, and moving patients through that system more quickly with a reduced length of stay and out the door into a predictable increased need for post-acute care, where that post-acute care is provided in a fragmented and highly mixed system of public and private financing, raises significant equity, potentially raises significant equity issues. And so that's something that we need to, think about is as a set of systems and as a country, whether or how we might mitigate those equity implications. So in conclusion, and I'm glad that we've got time now to kind of really get into some discussion in the question and answer. The fundamental finding of this study was that although there may have been a perception among Canadian policymakers that there is a strong evidence case for activity-based funding under certain circumstances, in fact, there is really a huge amount of variability in the international experience of activity-based funding. And so it is really only by selecting individual studies that support one's case that one can make a case that one knows what is going to happen when introducing activity-based funding into the hospital sector. And therefore, we really are, if Canadian jurisdictions are moving in this direction, doing something of a leap into the unknown, and that is going to require that we do some pretty substantial and thoughtful evaluation of our own as we move forward on this, keeping in mind the policy goals that we have as a set of healthcare systems. But certainly there is not nearly the clarity in the international evidence on activity-based funding that some might think. So we will stop there and I guess move to the questions and discussion.
Thank you, Danielle. I'll just before we go to that and before we go to Stephen Lewis's actual presentation as our policy commentator, I just wanted to let you know that we do have data, more data than we could publish in this study. So we stratified the studies according to the following outcomes that you can see here and subgroups, and we could abstract these data if anyone is interested in these outcomes, so we'd need some more funding to do that. But we have data on administrative burden, on efficiency, as Thomas mentioned earlier, on cost to payer and cost to hospital, on patient characteristics, some on upcoding. And we also stratified according to rural versus not rural facilities, for-profit versus not-for-profit facilities. We've already looked at the ABF in the acute care setting, and we have a whole other set of data on what happens in post-acute care when ABF is implemented there, as it was in the United States in about 2 decades after it was implemented in the acute care settings. And we also looked at the Ontario QBPs and stratified according to each of the QBPs on Ontario's list of quality-based procedures. So just to let you know that there are more data if you have any interest in that. So I'll turn it over to Stephen Lewis as our policy commentator.
Hello, and thank you. This is a very interesting session, and the first thing I want to say is to praise the research team for the heroic work that they have done in trying to get to the bottom of this story. I'm glad they had to do it and not me. I mean, it's a heroic amount of work to do these systematic reviews, and it's a real service to unpack what may have taken place internationally. Interestingly enough, of course, there are no Canadian studies here yet. And secondly, then, I want to say that you can only expect a study or a technique to do so much, and this is where I want to begin my comments. So, to me, I'm not surprised by the variability, and I'm not surprised by the one robust true effect outcome that they found. And the reason I'm not surprised about the variability is because, to me, it's not very plausible that ABF would explain a tremendous amount of the variance in anything. ABF is a funding technique, and while it sounds like it's very different, it's not like it's an innovation of untold dimensions. Over time, funding systems evolve, and by and large, the way we fund hospitals, the way anybody has funded hospitals historically and the way they fund them now, it's basically for activity. It's just whether you think you're calculating it on the basis of specific, discrete, disaggregated activity, or whether you're saying, look, you've got so many beds, you have a certain amount of acuity in your hospital, you're either a teaching hospital or a community hospital, you do some high-end things procedurally, you take complex patients. It's all a sort of aggregated activity-based funding lump sum by another name. Now, I do think ABF is a more precise version of this, and I think the theoretical advantage of ABF is that it makes you think hard about what things actually cost discretely. And secondarily, if your costs are higher than others, to identify why they're higher than others. So, to me, it's not implausible that just making people think about costs in terms of episodes of care by diagnostic group and complexity could lead to some efficiencies. But I think there are many good reasons for facilities to think about efficiencies regardless of whether they have ABF or not, because, and they're going to have to do a lot of the same things, which is if you really want to get a handle on your costs in a $600 million a year hospital, for example, you're going to have to go to the unit level and to the case level to find out regardless. So I think one could plausibly expect it to lead to some efficiencies, and from a systems perspective, which I am most interested in, I would say that it would be in finding from the purchasing perspective some economies of scale. There are economies of scale thresholds for most kinds of procedures in units, which imply that in some cases specialization and consolidation of services in one facility where you have the luxury of deciding where you want to buy from could actually result in lower unit costs simply because you do higher volumes and you can have dedicated ORs and shorter OR turnaround time, for example, in the case of procedures. I'm not so sure that there is such low-hanging fruit on the medical side of things, and where we have a multiply comorbid aging population with very highly acute medical needs on occasion, I suspect that ABF is a lot tougher methodologically to implement, but maybe the study authors have found that that's not actually the case. The second major cluster of outcomes relates to quality. So would we and could we plausibly expect ABF to improve quality? And my answer is, I doubt it. I don't think that an exclusive focus on episode costs is likely to improve quality. But paradoxically, I think that if you have a quality of care focus where you are paying attention to the processes of care and where you standardize care on the basis of evidence, most quality experts, and I think a not an inconsiderable number of studies would suggest that better quality is cheaper. So I guess what I would say is, if you want to have a more efficient system, you can treat efficiency as a direct financial calculated kind of investigation, or you could say, no, we're going to start from the premise that where we have variation in what is done, that signals a quality problem. We're going to address quality in all of the ways the quality improvement movement suggests you should address quality, and then we should be able to expect some financial efficiencies. I believe that is a more plausible mechanism of action than looking at ABF and instituting it or its cousins discreetly without, at least at the same time, and as a almost higher order endeavor to focus on the quality. So when you have a fascination for something like ABF and you want to implement it, it seems to me there are intended and unintended consequences. And again, I think the study authors have done a very good job of identifying what those might be. The intended consequence, and this relates to Danielle's point, the intended consequence of shortening hospital stays, I think, is logically and from a system standpoint an unobjectionable and probably a good thing. There may indeed be the unintended consequences of offloading burdens on people and in creating system gridlock in the community care sector if there isn't a good process for decanting the business and the money to look after people in a lower cost and more appropriate setting. That being the case, I don't think the solution is to be wary of shortening hospital stays and if discouraging people from going to alternate care settings. The solution is to look at the alternate care settings and make sure they're properly resourced, and also to make sure that people under the often neglected Canada Health Act principle of comprehensiveness actually get comprehensive services without incurring unreasonable additional financial burdens from moving out of the hospital to another form of care. Turning to technical efficiency and productivity, I think the biggest conceptual flaw of ABF is that the assumption is you know what you're buying and it's appropriate to buy it all, and therefore all you're looking at is the relationship of inputs to outputs, and although there appears not to be much impact in this case to outcomes. There's an enormous appropriateness problem in healthcare, and the biggest variations in cost are not between hospital episodes of care between facilities or communities, but in overall expenditures between communities, particularly in the United States where the great majority of these studies took place. So in the U.S. Medicare or elderly population, the total healthcare spending varies by about 3 to 1 from the highest to the lowest spending regions. Activity-based funding won't solve that problem. The problem is appropriateness, both in the diagnostic end and in the therapeutic end. In Canada, we probably don't have that much variation because of the way we fund the system. But we know, having done this work in Saskatchewan, and others have done it in Ontario, et cetera, there are major differences, huge differences, 3- and 4-fold differences in the rates of procedures done on a population basis between healthcare regions or communities. And ABF can't really address that issue. So ABF's potential to solve the problem of variation and variation in cost is actually pretty limited. And it seems to me that you're focusing far too downstream on the problem of deciding what is done, and it focuses on how it's done, when, again, I think the problem is what is done, is it all appropriate, and have we had those conversations about reducing variations in healthcare decision-making as opposed to healthcare activity. And just to conclude and throw it open for further conversation and questions, where do I think ABF could work the best if it's going to work at all? It seems to me it would work best in a thoroughly integrated system with a bit of a purchaser-provider mentality at its core. So to give you an example, the Group Health Cooperative in Seattle was a thoroughly vertically integrated healthcare system that owned its own facilities. It decided, however, that if it was going to achieve the best combination of cost and quality, it should get out of the hospital business. So it sold its hospitals, and it now only buys hospital care. So it controls appropriateness, and it also controls the care that people get in the hospital because it insists on using its own physicians, not the hospital-based physicians, to provide the care there. And it seems to me that is the best possible environment where ABF could work, because you do want a good handle on what things cost. You do want it to be as efficient as possible, but you are not ceding control over the decision to do or not to do a certain procedure or any other aspect of health care to the hospital itself. You're actually maintaining control over those other dimensions that I think are important. Again, in Canada, if in a regionalized healthcare system with a global regional budget, it seems to me in theory that the purchaser, which is also the provider, could make those decisions using an ABF lens about how it's going to fund hospitals, and it could really encourage either consolidations of care or efficiencies in care by moving money around. Now, in practice, I don't believe that we have enough precision in that, which will lead me to my final point. It seems to me that the calculative and measurement burdens inherent in making ABF work very well and also fairly are unlikely to be realized in practice. There will be variations in coding. There are variations in condition that are not captured by even the best case mix adjuster. Even if you got within 5 to 10% of standardization, so take your point estimates and then plus or minus 5 or 10%, that's still a lot of money and a lot of variation. Let's say it's 5%, and for certain categories of procedures, a hospital episode costs $10,000. Well, there's $10,000 could mean with a 5% variance, $9,500 or $10,500. Well, $1,000 per case multiplied by hundreds of cases or thousands of cases can be a lot of money, even within a single facility. I don't believe that 5% is the range. It's probably more like 10 or 15%, in which case you would have an enormous variation. So while ABF may get you a more precise calculation that we normally have or that we have under other systems, I don't think it's going to give you such a spectacular amount of precision that you could literally go to the bank on it, that you know exactly what it is you're buying and you know exactly what the differences are between facilities, and that a patient is a patient is a patient is a patient with utter precision. So to conclude, I would say it's a wildly optimistic notion that ABF by itself would accomplish very much in healthcare. It might accomplish something if it is combined as part of a general quality improvement strategy, in which case I would argue you probably don't need ABF by itself. You probably have other mechanisms that, again, focusing on quality would impel you to focus on efficiency, because people receiving the right care in the right place at the right time, if that's the triple quality mantra, I believe that it does imply efficiency and that you may get the efficiencies indirectly rather than directly. So again, thanks for the opportunity to participate. Congratulations again on the study, and I look forward to everybody's questions.
Thank you very much, Stephen, and thank you to Danielle, Thomas, and Karen for your thoughtful presentations today. We are moving now into the questions and discussion portion of the webinar, and we do have a number of thoughtful questions already lined up in the queue, so without further ado, I will start reading those. If you have not had a chance to contribute to the discussion, to the chat box yet, you'll find it on the bottom right-hand corner of your screen. And please remember that when you type your questions, address them to all participants so that everyone can see. We have about 30 minutes for this discussion, so let's launch into it right now. Our first question is from Claude Lemay, and he's wondering if this question is directed to the research team. Have the researchers envisioned looking at the outcomes in the form of complications, example, infections, pneumonias, falls, or drug errors?
It's Karen. I'll start with that. We envisioned looking at many things. It took us 2.5 years to give you what we gave you today. anytime you want to look at one of these variables, it means combing through the literature again, screening it all again, and looking for the particular outcome that you're interested in. The one complication that we did look at was mortality. We considered, I think that would be a complication. But certainly all of these other variables, infections, pneumonias, falls, drug errors, we could look at, and they would be interesting. Thomas, do you have anything to add to that?
Yes, these were categorized into these 75 studies that I've shown you in the list of outcomes as quality of care indicators. So typically, these would be quality of care indicators in those studies. And we know there are 75 studies, many of which are already now reviewed for the outcomes you've seen, that reported on some of these indicators. Now it's both interesting to look more closely at each one of them, but as you do this, you also lose any ability to draw general conclusions because you start reducing it to fewer and fewer studies on each of these outcomes, 1, 2, or 3 at a time.
It's Danielle. I would just add one more thought to this, which is that although it's true that we did not look specifically at the question around sort of errors and complications under ABF, I think a couple of, maybe this is my clinical perspective, a couple of assumptions are probably safe to make. The first is that if there were an increase in complications, infections, and errors under activity-based funding, it doesn't increase length of stay. So most of the time, a really significant error with a substantial adverse outcome you would think would either affect mortality rates or affect length of stay. And the literature on ABF around length of stay, there's enough of it out there suggesting that ABF decreases, not increases length of stay, that one can probably draw some conclusions around that. The second observation I would make is that you might see an increase in readmission if you have people who are, for example, discharged with an early hospital-acquired infection who need to come back, and we haven't seen that. And then the third is that we didn't see an increase in mortality in post-acute care. So although there's an increase in the number of people going into some form of post-acute care, there is not an increase in the rate of death in post-acute care with the introduction of ABF. So that's not to say that there might not be an increase in complications, but just to kind of provide a little bit of context around what I think the inferences that one might draw are, that one might draw from the data that we have looked at.
Okay, thanks very much to the research team for fielding that question. Next question is, was there a direct cause and effect relationship between ABF implementation and post-acute care?
I could give some thought on that if you like. Karen, would you like to start?
No, go ahead. I would say that if you were going to look at direct cause and effect, we would need an RCT, and we didn't have any RCTs. But Thomas, what would you say?
Yes, exactly. I mean, most of these studies are inherently observational, and several of the questions ask if they study for other confounders or trends, such as increasing in aging groups. I just saw a question on whether the study controlled for innovations or technological factors. Anything that can change with time and across institutions could affect the results because they were observational. So speaking of cause here, I think it is going much too far. But on another hand, we were very interested in that. And that's why we did subgroup analysis comparing the studies that did some adjustment with the ones that did not. The ones who just compared a before-after study design, very sensitive to trends, with other designs that are less sensitive to trends. And overall, comparing results of higher credibility studies, if you take into account everything, compared to lower credibility studies. And we never found a difference in the results if you did those sensitivity analysis, if you like. So no, we cannot speak about cause and effect. I think this is going too far, but there doesn't seem to be clear signs than that the confounders hugely affect the estimates you see.
Thank you, Thomas. The next question follows up on that same issue of post-acute care, and they're wondering if you've screened the CIHI data specifically on post-acute care in Canada to see if there's a general increase or decrease in percentage.
Thomas, do you want to talk about that? I mean, the CIHI data, if the CIHI data were published or they were in some sort of gray literature report, we would have screened them if they were published between 1980 and 2012 when we ended the search.
I don't remember if we had them specifically, but I guess the question again is to see whether this gives an indication of the confounding, right? If there was, if I understand correctly, if there is a trend in general in what happens in the post-acute care settings.
So just to add to that, like maybe someone from CIHI wants to jump in and add some specifics, but what we were looking for was studies that compared a world without ABF to a world with ABF. And so if there are CIHI data that specifically compare either a pre-post or two jurisdictions, one where ABF was implemented and another where ABF was not implemented, and looked at post-acute care, then those data would have qualified for inclusion in our study. But I'm not aware of any such comparisons in the CIHI data offhand. So I don't, CIHI may have lots of data on post-acute care, but not on what happens to rates of utilization of post-acute care when activity-based funding is introduced, I don't think. If those data exist and were published, then they would have been included.
Yeah, you have to remember that we aren't doing the primary research here. We're reviewing the published, peer-reviewed, and gray literature that exists. So we could certainly, we could look at the CIHI data, but I mean, we don't have activity-based funding implemented other than in Ontario and a little bit in British Columbia. And there have been a few studies, and we certainly looked at the ones in BC, for instance, the one that has been published on volume of care and showed no difference in volume of care in very preliminary results.
Okay, thank you. The next question coming in is, did you find any data quality monitoring activities that help to prevent or monitor for upcoding? If yes, where? And did you notice any differences in the results?
Which question is this? Whose question is it from? I just wanted to see it on the screen.
Jose Valleran.
Okay.
So I'll read it again. Did you find any data quality monitoring activities that help to prevent or monitor for upcoding? If yes, where? And did you notice any differences in the results or impact?
So I think the answer is no.
Yeah, exactly. The answer is no. We didn't. Interestingly, and there's I mean, Karen and I have discussed the possibility that the next round of this work might be specifically to look at some of this work around upcoding, because there's a lot of stuff out there about upcoding. And again, it's hard to say how much of the upcoding that goes on is legitimate, increases in accuracy of coding, and how much of it is intentional upcoding to maximize hospital remuneration. But there sure is a lot of evidence relating to upcoding out there. I don't remember seeing any papers that talked about a jurisdiction that has successfully protected itself against the effects of nefarious upcoding. But it certainly would be a great thing for policymakers to be thinking about if we're going to be implementing this kind of hospital financing model in Canada. I mean, of course you want, it stands to reason that if you're going to implement activity-based funding of some form, you want to adjust how much you pay institutions based on how sick their patients are, of course. I mean, you wouldn't want a situation where you would pay everybody the same fee regardless of how sick the person is. That would create all kinds of other terrible perverse incentives. But the particular perverse incentive around upcoding seems to be real.
And in fact, when activity-based funding first started, there wasn't a severity adjustment for it, and hospitals realized that they needed to add one over time. So, the severity adjustment became the DRGS for severity. But in terms of the data quality monitoring activities, we didn't look at that.
And Stephen here, this is why I think the whole enterprise has a real conceptual dilemma in it. The public interest is twofold. We want accurate, comprehensive coding for quality of healthcare and epidemiological purposes. We also want efficiency. If you marry the two together, and if people know that funding is going to be a function of the way you code, no one is ever going to eliminate upcoding. And in fact, you may get a secular trend about upcoding, where everybody's doing it more or less the same, but it's still excessive. So it seems to me we need to go back to the future a little bit and talk about population-based funding and let an integrated system figure out how to find its own efficiencies. It will certainly do what Danielle and others have said, which I agree with. Of course, you would not want to fund Hospital A that has routinely uncomplicated cases as much as complicated B, but I think there are other ways to do it than activity-based funding. And what you also want to do is find a way to reward an organization, an integrated one, for getting out of business as opposed to just doing business. Avoiding care is a tremendous triumph, and under any ABF system or its cousins, you lose money for that, which strikes me as the most perverse incentive of all.
Okay, thanks everyone. I'm going to read the next question from Cheryl Stanichuk, and she's asking, could the increase in discharge to post-acute care be related to an aging population, which would be more likely to require post-acute care, or did the studies already account for the age of population?
Thomas speaking. Some studies did account for age. Actually, there was one of the adjustment that was most commonly done when adjustment was performed. But again, other studies did not adjust at all. So what is striking is that when you compare the one that adjusted and the one that did not adjust, that the results are pretty similar. So this is an indication that the trends in age groups, in age distribution, probably do not explain that degree of increase, 24% relative increase. The other thing is also the timing. Some studies looked at the impact of ABF early, very early after its implementation, while others looked later. And when you consider that very early, it's really a short before after that cannot be really affected by trends. And again, if you compare the impact of ABF early after implementation or late, there was no real difference. So I don't have a clear final answer, but no indication that the trends in age could ever explain that increase in rates, a 24% relative increase in my view.
Amanda?
Oh, sorry, I was on mute there. The next question is from Claude Lemay, and he's asking if there's any data to the effect that going to ABF has forced or encouraged the standardization of care based on evidence.
I mean, none. I'm sure there are data. It's not what we were looking for, was a measure of standardization of care. But it seems a logical outcome of going to a funding system that pays a certain amount for certain diagnoses, is that there could be some standardization of care, but that's pure speculation. Danielle, do you have any sense of that?
No, I mean, so, and I guess I probably should point out that, my participation in this conversation is purely as an individual with my researcher hat on and not representative of my organization before I launch into hospital responses to activity-based funding. I think it is probably, again, this is not based on the literature, but based on logic, which sometimes points us in the wrong direction. But I do think that there is a logical response on the part of hospitals to try to standardize in response to activity-based funding. And that is probably what accounts for what we know takes place, which is a reduction in length of stay. I mean, one can assume, at least in part, that the reduction in length of stay is not solely because of kind of haphazard changes to care processes, but in, to some kind of standardized approach to the provision of care. Now, how much of that approach, that standardized approach, would be based on best evidence, as you say, and therefore potentially even reflect an increase in quality, is anybody's guess. At least our data suggests that people aren't more likely to die, so it doesn't seem to stem from a significant reduction in quality, at least not so far as it affects the bottom line. The most important outcome reflecting quality being mortality. But other than that, I think, anything more than, even that is pure speculation. Anything more than that would be over speculation.
Yeah, the one standardization that we do tend to see is that length of stay is shortened, and that for each DRG there's a length of stay built into the calculation of that DRG. And again, we didn't spend our time looking at how the costing works, and there's a huge number of costing studies out there. But for instance, in the United States, we ultimately saw a law put in place to require hospitals not to discharge a woman after childbirth in less than 24 hours unless she wanted to be discharged in that short of a period of time, because the DRG encouraged shorter discharge. So I guess if that's a form of encouraging standardization of care, which is a shorter length of stay, then to some extent it does that. Next question, please.
I just would like to add something. Sorry.
Just a reminder,
Thomas is adding.
10 minutes left for the Q&A, so I'll try and get through as many questions as we can. We have quite a lineup here, which is great. So the next question will be from Kelly Stanistreet, and her question is, since there has been no change in volume of care, has ABF resulted in any cost savings for hospital care? If so, perhaps these savings can be redirected towards post-acute care.
So as I mentioned, we have a big volume of studies on cost that we have not analyzed, and same with the efficiency data. There was another question on efficiency, and did we see anything on efficiency? So I'll address cost and efficiency in this question, and the answer is that we have the data. The cost data are tricky to analyze because they span 30 years in different currencies with different purchasing power parity. So we would need a smart economist to help us out with figuring out how we would compare over time and over currencies to the cost data.
Thanks, Karen. Next question is from Gord Croucher. Did any of the studies look at the impact on ABF on adjusting protocols to introduce new, possibly more costly interventions?
So I can answer that, and it was what I wanted to say earlier regarding actually what happens at the point of care in an institution or at the level of organization of care. Our eligibility criteria captured any study that compared ABF, we know ABF. And in none of them did we see any true measure of what happened at the point of care. So whether there was more standardized care or less standardized care, what were the actual procedures. In other words, how the care teams answered to the incentive. And this is probably also relates to what Stephen said. We were able to capture all these studies, and in none of these studies was the actual observation of what happens as a result of the incentive measured.
Okay. Thank you. The question from Drew McNeil next asks a little bit about efficiency. So they were mentioning, says you mentioned that 20 studies looked at efficiency. Could anyone speak to what these studies had to say specifically about ABF's impact on efficiency?
So we have the data on these studies, and I could certainly speculate, and that is exactly what I'm not going to do, because the bias that we all read into studies when we read them would reveal itself. And so that's why we did a systematic review, and we would be happy to look at the 20 studies on efficiency and systematically review them, which is the only way we can know what the efficiency story is.
Thanks, Karen. The next question is from Stephen Elliott Buckley, and his question is, if there are no substantial and clear ABF healthcare advantages that have been demonstrated, particularly before anyone ever started ABF, could it just be an attempt to move away from block funding for hospitals to facilitate privatizing elements of acute care?
Thank you, Stephen.
Stephen, do you want to comment on that?
Well, I don't know. I mean, I think if you want to do that, you don't have to. It would be a pretty Byzantine sort of strategy to say we're going to do ABF and then, because that's the thin edge of the wedge, to privatize. I mean, I guess the way it would work was the way it's already worked in some cases where you have facilities bidding, independent health facilities bidding on high volume procedures but publicly funded, and then offering some private services on the side. I think that's a bigger issue, and I think if that was really the agenda, I'm not so sure that ABF would help you all that much get there, but you know, who knows? Who knows why they do it? I mean, I think the main reason they do it is they're desperate for some kind of cost containment. Ironically, the cost containment in Canada has been already most successful in the hospital sector, but governments are still trying to hope for some magic bullet that's going to make it remarkably more efficient than it already is, and I just think it's overly optimistic.
I unfortunately disconnected. Sorry, I didn't hear all of Stephen's answer, but what I will say about activity-based funding is that it does break care into saleable units, and so I suppose that the incentive is to distribute those units to the most efficient and cost-effective provider. And so that would depend on whether the system had competition between the for-profit and the not-for-profit sector as to who was more efficient.
Okay, thank you. So the next question is from Rebecca Hancock-Howard, and it's a bit long, so bear with me here. It says, I appreciate the description of results by U.S. and international settings. Are there any concerns with the majority of the studies, 50 out of 65, being from the U.S., given that, 1, most of these studies appear to be from the late 80s to early 90s, and 2, that the nature of healthcare in the U.S. is overall so different from Canada? And then the second component of that question is, what happens if you restrict the analysis to more recent studies from settings that have primarily public systems? Well, would probably not have enough poolable data, but what about non-poolable analysis? So there may be a team to tackle that one. But
I'll just speak for a second on that, and then probably Thomas will do a better job of answering it. But we did look at this in terms of the U.S. versus international subgroup analysis, because the international countries, the other countries other than the U.S., have primarily public systems. So whatever the results show in those subgroup analyses would answer this question. Thomas, do you have a comment on
exactly. Nothing really to add. We can only analyze it by proxy indirectly, and the analysis Karen just said, the U.S. versus the more recent international studies, sort of addresses the two questions in one, because it so happens that the international studies are more recent and more often in a primarily public system. We cannot, with the, as you can see in our questions repeatedly, we are limited by the evidence that is existing, and this is our main finding: is how much the evidence leaves us with a lot of uncertainty about the impact of ABF and how it can vary across different settings. So when we present these results, we have lots of questions about the potential explanation, but you can see by our answers that the available evidence often doesn't answer them. So that's why we use the image of leap into the unknown, or leap of faith, because we cannot go further than what we've just presented.
Thanks, Thomas and Karen. I think you might have touched a little bit on this already, but I'm going to read out the next question from Nazish Samad, and he's wondering if the study controlled for innovations and technological factors.
No, they did not.
It did not. You know, first you'd have to identify all the innovations and all the technological factors and all of the other things that could contribute to secular trends. Then you'd have to stratify the data according to each of those things, and then you'd have to do the analysis. And with so few studies in the first place, you'd end up with results that were pretty much, I think, meaningless. Thomas, do you agree with that?
Yeah, exactly.
Okay.
I mean, this is not the world of the randomized controlled trial, and in fact, as you all would recognize, even in Canada, it's not as though we're talking about implementing activity-based funding and not doing any other changes at the same time. Healthcare systems and healthcare policy is constantly shifting, and so the purpose of a systematic review like this is not to isolate every single individual factor, but rather to look internationally and say, what can we learn from other countries that have gone down this road that we are actively talking about going down in Canada? Is it reliably the case that activity-based funding increases volumes of care and therefore could be a solution to our wait time problems? Is it reliably the case that activity-based funding controls costs in healthcare systems? Is it reliably the case that it reduces length of stay, and are there quality implications for that around mortality, readmission rates? Are there other things we need to be aware of that have taken place in other countries when activity-based funding was implemented, so that we don't, end up with a bunch of unintended consequences? And the findings and the learnings will always be general and will always have to be taken with a grain of salt, because, of course, all of that activity-based funding implementation took place in systems that were constantly shifting in other ways. But our major finding, which is about a very significant increased need for post-acute care supports for patients in a world of activity-based funding, should give policymakers some pause, I think, in the Canadian context, and should make us think about, is our post-acute care system robust enough? Is it ready? Could it absorb a significant increase? And what are the equity implications of it, given that we are not in a world where Medicare covers home care and post-acute care? And that's, to me, that's the general take-home message.
Thanks, everyone. Unfortunately, we've come to the end of our time here today, so just quickly I want to remind you that in a few moments a survey will pop up on your screen. We really would appreciate your feedback on this to help improve future webinars in our series. Also, I'd just like to apologize that we didn't get through all the questions. If you did pose a question and didn't get the answer you were hoping for, or didn't have a chance for us to read it out, we do have contact information here for all the panelists today, as well as CIHR representatives who work on the policy rounds. There was a question as well asking about the dissemination plan of these very useful results of the research today, and we will be sharing some links with some of the great KT work that the research team has done on this project so far. So we will be sharing a little bit more of information with you through a post-webinar email, as well as slides for the presentation today. So again, I would just like to thank everyone for our great presentations today and for your active participation. Our next policy round will be held in February 2015, and we'll discuss creating a sustainable system of care for older people with complex care needs. And details of that will be posted early in the new year on our website, so please stay tuned for that. And with that, I'll just sign off and thank you again on behalf of CIHR for joining us today.